Good morning and welcome to the Common Part B Nurse Practitioner Rejections and Denials webinar. I'm Mary Moko and I am a member of the WPS Provider Outreach and Education team, and I'll be your host today. Joining me with some behind the scenes help is my friend and colleague, Bailey Lawson. This webinar today is for those people who are wishing to learn about the most common reasons that WPS rejects and denies Part B claims for nurse practitioners. You might be wondering why I chose to deliver education on this topic. It is in their internet-only manuals that CMS requires the MACs to look at the most common rejections and denials and plan education strategies to prevent future claim rejections and denials. And just as advertised, the information that I'm going to present to you today during this live webinar is based on actual claims data. Next slide. Here is the objective and the agenda. Obviously, we are providing this education today to help avoid rejected and denied claims. Now, the agenda should look really familiar to you because this is exactly the bullets that I included in the description that was included when you viewed the description of this webinar and registered for it. I'm going to define rejections and denials and talk a little bit about the differences between them, and then I'll reveal the reasons for rejections and denials for nurse practitioner claims based on actual WPS claims data. I'm going to talk about ways to fix or avoid these, and along the way I'm going to provide many resources to you. Next slide. We begin this presentation today talking about the claim process. Next slide. Now, based on a law that requires it, most providers do submit claims electronically to Medicare. There are reports that generate to confirm claim receipt and to report more specific information about the data requirements of those claims. Now, one of these reports is the 276-277 report. The Medicare 276-277 Companion Guide is one that's prepared by our Electronic Data Interchange, or EDI staff, and this helps submitters understand claim requirements, and it also helps them know when they need to correct or resubmit the claims to Medicare, to WPS specifically, if you're a J5 or J8 provider. These reports will actually let you know if that claim got in the door, so to say. On the next slide then, I provided some information to you about the remittance advice. There are two formats, the electronic remittance advice, or the ERA, and the standard paper remittance, or the SPR. Now, with few exceptions, most providers, of course, are going to receive that electronic version. The remittance advice, or the RA, some people call it the notice or just shorten it up to remit, provides important information to the provider. For those claims that are adjudicated, you can find information about adjustments and denials, missing items, and even sometimes refunds and offsets. On the next slide, when looking at a remit, you will find various reason and remark codes. Now, these are typically in an alphanumeric format. When claims pay different than they were billed, a claim adjustment reason code will appear on the remittance advice, and sometimes a remittance advice remark code will also appear, and these expand on the details that are described by that reason code and do so in order to provide more details about the adjustment to the claim. On the next slide then, we talk about another type of code on the remittance advice, and those are group codes. Group codes assign financial liability for any unpaid balance on the claim. So if you see a CO group code on the remittance advice, that stands for contractual obligation, and that means that the provider is liable and you can't bill their patient. Now, a PR group code, on the other hand, means that the patient is financially responsible. Next slide. We hear a lot of comments about these codes that appear on the remittance advice, and providers often state that the codes are too cryptic or that they contain outdated information, such as an outdated acronym. While we at WPS would really like to help, it is another contractor, not WPS, that maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website, and it is on their website where you can find contact information should you wish to suggest a change to the code lists, including those sometimes cryptic code explanations. You might notice on the presentation, on this slide and in the presentation materials that were available to you, um, that there are a lot of embedded links included in this information that I've provided. So you can come back to these great resources following today's live program. On the next slide, I have provided for you some information about rejections. Rejections are never adjudicated. They are unprocessable, as CMS calls them. They're rejected. They're returned on the front end. And the reason that we return these on the front end is that something's illogical, something's missing, or there's incorrect information on that claim. Something just doesn't make sense. Because these are never adjudicated, these claims do not have appeal rights. What you need to do is fix it and resubmit it. On your remittance advice for a rejected claim, you will see an MA130 and a CO16 code. The patient is not liable. You need to fix it and resubmit it. I'm talking about rejections right now. Next, on the next slide, I'm going to talk about denials. These are really different. A rejection is very, very different from a denial. And I think a lot of us, myself included, I find myself sometimes doing this. I'll interchange these words, and we really shouldn't do that because the actions to fix it or the actions to get your payment are really different. A denial, unlike a rejection, is actually adjudicated. We adjudicate the claim. The reason we denied claims can be very many. I've included some of them here on this slide. Maybe the service that is being billed is simply not covered based on law. That's called a statutory requirement, a reason we have to deny that service. Sometimes we deny services because they don't meet medical necessity. And any frequency parameters or utilization guidelines that are used during claim processing are considered a medical necessity denial. Those are those situations where you should consider presenting your patient in advance with the Advanced Beneficiary Notice of Non-Coverage, the ABN. Other denials could include those situations where Medicare makes a denial based on eligibility. Now, that eligibility could be the eligibility of the patient, or it could be eligibility of the provider or the provider's clinic. So these are just a few examples of denied claims. Now, on the remittance advice, most often, I'm going to say with few exceptions, you will find an MA01 code, and that means that you have the right to an appeal. There are very few situations where Medicare denies a service where we don't allow an appeal right. Most often, with few exceptions, we do. And that's when you'll see that MA01 code on the remit. For denied services, patient liability is determined. During the next portion of the presentation, I'm going to start talking a little bit about whether you need to correct your claim or if you need to appeal the claim or the claim decision. Next slide, please. Here is where I have listed some potential actions to choose, and this of course is the situation I talked about earlier where you really need to know the difference between a rejection and a denial because it makes a difference upon makes a difference as to the action that you need to take. For a rejected claim or an unprocessable claim, you need to fix it and resubmit it. Now, if the claim or a claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service, just like you do for a rejected claim. You might use the clerical error reopening process to fix a clerical error. And CMS defines clerical errors as human or mechanical errors on the part of the provider or the contractor. Another action to consider for a denied service is an appeal. The remittance advice will provide appeal rights when there are appeal rights. Registered users of our SecureNet Access Portal, or SNAP, can render or request a clerical error reopening or request an appeal. SNAP is that secure side of the WPS portal or our website. This is a self-service tool, or these are the clerical error reopening and the requesting an appeal. These are self-service tools that really do offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use these portal features, and you can find a link to the portal user manual on each and every one of our web pages. The next couple of slides go into a little bit of information about appeals. I couldn't talk about denials without giving you a little information about appeals, so I've done so on the next couple of slides. For claim denials, most often you can request an appeal, and the purpose of the appeals process is to ensure the correct adjudications of claims. Now, physicians, suppliers, non-physician practitioners, and representatives of the beneficiary and the beneficiary all have the right to appeal claim determinations that are made by the MACs. And if you're not familiar with that acronym, MAC, M-A-C, it stands for Medicare Administrative Contractor, and WPS is a MAC. Now, the beneficiary or their representative may request an appeal on any service that's processed for them. Providers and suppliers may appeal services for which they accepted assignment. Now, for unassigned claims, though, providers and suppliers can act as the beneficiary's representative, but the beneficiary needs to sign an authorization statement. Now, in addition, providers and suppliers can also request a redetermination on an unassigned claim for a couple of reasons. If Medicare denied that service is not reasonable and necessary, or if the provider or supplier billed in excess of the limiting charge. And in that case, they would need to refund any excess amounts that they've collected from the beneficiary. Now, the first level of appeal is the only level of appeal that is rendered by the MAC. Time frames apply to each level when you are submitting an appeal, and additionally there's a minimum amount in controversy that applies to levels 3 and 5. This is a dollar threshold that you need to reach in order to request that level of appeal, and you can combine like denials on more than one claim for different patients even in order to reach that amount in controversy, or the AIC. The next slide includes a couple of my the resources that I have provided for you. The first one is a resource that appears on the WPS website. It's called How to Appeal a Claim Determination. It tells you step by step the process for requesting an appeal. It also tells you where you need to send the appeal, or how you can do the appeal, or the fact that you can do the appeal rather, or request an appeal by using the SecureNet Access Portal. The next resource is a flowchart, and it's one of my personal favorites, so I do like to share this with folks. If you look to the right side of this slide, you're going to see a graphic, and this is where I typically would open this flowchart. And Bailey's actually showing for me today, so I can't open it to show you. But the flow chart, when you look at it online, is great because it shows you your initial claim determination. That's when Medicare processes your claim, or WPS does. And then it shows you the first level, the second level, the third, fourth, and fifth level of appeal. It will tell you the name of that appeal level. For example, level 1 is redetermination, level 2 is reconsideration. Level 3, of course, is the Office of Medicare Hearings and Appeals. Sometimes we call that an ALJ hearing, that administrative law judge hearing. Level 4 is the Medicare Appeals Court. And then level 5 is review in federal district court, or federal judicial court. For each of these levels, it gives you the time limit, the number of days you have to request an appeal. Within each of these boxes, where it gives you the name of the appeal level and the name of the contractor, it gives you the number of days that that contractor or that entity has to render their decision and send you notice of the decision. Remember that I said levels 3 and 5 had that amount in controversy or that dollar threshold that you need to reach in order to request that level of appeal. That's here on this worksheet, or this flow chart rather. When you look at it online, you'll see that the amount in controversy for a level 3 appeal is greater than or equal to $190. And for federal district court, the amount in controversy is greater than or equal to $1,900. I do want to point out to you that those AIC amounts can change from year to year, and most often they do. At the very bottom of the flow chart, when you're looking at it online, take note of the date that you'll see. For example, the current one states that the chart reflects the amounts for the calendar year 2025. We're getting pretty close to the end of this year, so you'll want to make certain, if you refer to this flow chart online, that you are looking at the 2026 version as soon as January comes along. Make certain that CMS has had ample time to go in and update that flow chart. Again, one of my favorites. I just wanted to share it with you. I'm going to pause for just a moment as we move to the next slide. Here starts the next portion then of what I advertised I was going to cover today, and this is really what we're focusing on. In order to view the data that I'm going to share with you, I used a tool that we call the data dashboard. We use this tool to pull data, to view data, in order to determine the needs for education for our provider community. The data dashboard is an interactive tool that was designed by our data analysts in our Insight department. That's just the name of the unit at WPS that's responsible for mining data, data trends, among other tasks, of course, and other responsibilities that they have. The next slide shows you different ways we can view the data. And literally, with the click of my mouse, I can choose to look at data by rejections, or I can choose to look at denials. I can look at one state. I can look at our entire J5 jurisdiction, jurisdiction 5, jurisdiction 8. I can choose to look at the data by the reason why that particular, or why our claims are rejecting or denying. I can even put in a CPT or HCPCS code if I want to select data for a particular code. And it's literally by clicking that mouse or clicking or hitting enter, the key on my keyboard, that this data changes. It's just boom, boom, boom. I can also look at data by specialty and look at trending. So for today, I looked at specialty 50 data. That is a 2-digit specialty code that is assigned to a Medicare enrolled nurse practitioner. I looked at, excuse me, claims in jurisdictions 5 and 8. So this would include Part B claims. I didn't look at A data for Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. The dates that were the newest submission dates to view when I looked at the data and analyzed it to present to you today were July 1 of 2025 through September 30th of 2025, and the data was last refreshed by the data analysts in our Insight department on October 13th. So this is really the latest and greatest information we could provide you. Next slide, please. Here then is the data that I advertised I would present during this particular webinar today. It is only specialty 50 or nurse practitioner claims. These are the most common reasons that WPS rejected claims for nurse practitioners. The number one reason we rejected claims, and remember, rejected claims are not adjudicated, you need to fix it, resubmit it, is that a PA, NP, or CNS. PA is physician assistant. CNS, of course, is certified nurse specialist, or clinical nurse specialist rather, was not internally associated with the billing provider. That means in the enrollment records at WPS, you're not associating with your clinic. So the NP is not associated with the billing group's tax identification or tax ID. So for that, in order to fix it, resubmit it, you're going to need to contact provider enrollment and make certain that you are associated with the billing provider with their tax ID. Second most common Part B claim rejection is missing, incomplete, or invalid ordering primary identifier. CMS has published in its internet-only manuals, and these are the links are included in the resource section of your handout materials. They've published both for the Part A claim and the Part B claim a claim form instruction, what you need to put where on the claim. To take that a step further, because that information relates to a paper claim, one of the resources that I've included in the presentation materials is a link to what we call the crosswalk, or the claims crosswalk. I'll point that out to you later when I get to that slide. But what that crosswalk does is it pulls up an Excel spreadsheet, and it has the first column is a number or item number on a claim form. So item number 1 or box number 1 on the claim form. Where does that go on the electronic claim form? It crosswalks from a paper claim to an electronic claim. What is the information? Is it required, or is it situational that you need to enter that on the claim form? So it goes from item 1 all the way to item 32 or 33. All of the items on the claim form. It crosswalks from that paper claim form to the electronic version. So if you, for example, leave off a required element when you're submitting your electronic claim, guess what's going to happen? That claim is going to reject. You need to fix it and resubmit it. If something on your claim doesn't make sense, so if in one box you told us, yes, the beneficiary has another insurance, but you didn't put in that conditional information in another box, you're going to get notice on your remit of whether that claim rejected or denied. So illogical, things that don't make sense, things that don't go together. If it's not there and it's required, it's going to reject. You need to fix it, resubmit it. Incomplete, invalid plan information for other insurance. This is exactly what I just talked about. So you told us that the beneficiary has another plan, another insurance, but you didn't give us the plan information on the claim. So it's going to reject. You need to fix it, resubmit it. Next most common reason for denial is that the claim must be submitted to RRB, and RRB is what prints out on the remit, but it stands for Railroad Retirement Board. That means that that beneficiary is a retiree of the railroad, and you must submit their claims to the Railroad Board specialty contractor, which is Palmetto GBA. WPS does not process claims for Railroad Retirement Board beneficiaries. They need to go to the specialty contractor. Next, facility, lab name and address or PIN is missing. Remember I told you about those claim form instructions, and CMS says in them what's required, what's not required. Well, this is a required element. You need to place this information on the claim. If it's missing, your claim will reject. Invalid or missing modifier is the next one. Pretty straightforward. For this, I would recommend that you take a look at our modifier fact sheets available on our website. I've included a link to that in your resource slides at the end of this presentation. Now, remember, for a lot of these, maybe the reason why it's wrong is that it was just simply typed wrong. So it might be there, but it's invalid. Maybe you just reversed something when you were typing the information in or entering the information into the electronic claim. So these are all things to think about. Next slide, please. Let's take a look at a few more reasons, the most common reasons for rejected claims. Part B, nurse practitioner. CLIA number is invalid or missing. Well, you might be asking, what does CLIA mean? CLIA stands for Clinical Laboratory Improvement Amendments, and this is a law. CLIA regulations ensure the accuracy and reliability of lab test results. Labs require a CLIA certification, and CMS, upon successful certification, will assign a CLIA number. That CLIA or certification number must be entered on the claim form in item number or box 23 or the electronic equivalent. If it's invalid or missing, your claim is going to reject. Next, missing, incomplete, invalid billing provider primary identifier. That other rejection was that the ordering provider information wasn't correct or was incomplete or invalid. In this case, it's the primary identifier, primary provider. Next, similar to the one we talked about, this claim has been forwarded to Palmetto. Some insurers that are secondary to Medicare have an agreement with Medicare that they will pay us to forward claim information on to another entity. It's called a trading partner agreement. And in this case, the other insurer has entered into a trading partner agreement with WPS to go ahead and forward those claims for railroad retirement beneficiaries directly to Palmetto. So we do it for you. So this is informational. It tells you that the claim is rejected. It's being forwarded to Palmetto, which is the Railroad Retirement Board specialty contractor. Next, the clinic number is missing or wasn't entered correctly. Check that clinic number on the claim form. Make certain it's there, that it was entered correctly. And the next is patient is not enrolled in demo at the time services were rendered. And this refers to the guide demo, and I'm going to pull it up over here on the guide model. GUIDE, guide model. It stands for Guiding and Improved Dementia Experience Model. It is a voluntary nationwide model that aims to support people with dementia and their unpaid caregivers. So there is a list of participants available on CMS's website, those entities or organizations that agreed to enter into this payment model. So there's a guide participant list on CMS's website. And in a nutshell, the reason for this rejection is because that entity billed for a beneficiary before they were enrolled in that demo. You need to fix it, resubmit it. Okay, that is the guide model, Guiding and Improved Dementia Experience Model. And again, I have included in your resources at the end of this the slide deck or the presentation materials a list of all of these resources that are available to you to help you fix and resubmit these claims that were rejected or help you with the denied claims that we're going to talk about here in a little bit. Next slide, please. I thought it would be interesting to tell you not only the reasons for those most common rejections for nurse practitioner claims, but also to talk a little bit about the codes. Remember when I talked about ways we can view data? I said that we can view by code. So what I did here was I looked at the top reasons for rejections for your specialty, nurse practitioner, and then I took note of the top codes that we're hitting for nurse practitioner rejected claims. And the number one rejected code for specialty 50 nurse practitioner claims Part B at WPS is 99309. And then what I've done here is I've entered for each code those most common reasons for rejection. 99309 is a subsequent nursing facility care code. And it's being rejected. The number one reason is because the treatment was rendered in an inappropriate or invalid place of service. This is one of those kind of cryptic reasons for rejection. What this actually means is that there was a notification to Medicare that this particular beneficiary on this date, or this same date as this 99309 was billed, was actually in a Part A covered stay in a skilled nursing facility. And what's happening is this code is for a nursing facility, not a skilled nursing facility. So it's being rejected. You need to fix it, resubmit it. Missing, incomplete, invalid billing, primary or provider primary identifier is the second most common reason for this rejection. 99214 is that established office visit with moderate level of medical decision making. Could also be billed based on time. Incomplete, invalid plan information for other insurance was the top reason it was rejected. And the second most common reason why we are rejecting that code for nurse practitioner claims is PA, NP, or CNS is not internally associated with the billing provider. That means the nurse practitioner was not associated with that billing provider's tax ID. So that's a provider enrollment issue. Next slide. Let's look at more CPT codes and why they are rejecting for Specialty 50 Part B claims. Treatment rendered in an inappropriate or invalid place of service. This is similar to the 99309, that there's a notification to Medicare that the beneficiary was in a Part A covered stay. So therefore, we're rejecting because of the invalid place of service. Similar to the last code we talked about, the 99214, and P is not internally associated with billing provider. 99213 is established patient officer outpatient visit with moderate complexity. Those are two reasons that we've talked about already. Next slide. 82948. So this is one of those lab services. It's actually a blood glucose testing using a strip. The number one reason why we are rejecting this very commonly rejected code for nurse practitioners is that the CLIA number is invalid or missing. That is that certification number that must be entered on the claim in item or box 23 or the electronic equivalent. The other reason we reject this code is that there's a missing or incomplete or invalid ordering primary identifier. I didn't talk about this yet, but in the presentation materials at the I have listed for you a CMS resource that is a referring or ordering provider list. CMS makes available on their website this list of providers and their national provider identifier, their NPI, all of the providers that can refer or order in the Medicare program. So make certain if it's missing that you place it on the claim. Fix it, resubmit it. If it's incomplete, make certain you complete it and resubmit it. If it's an invalid identifier, make certain you have the correct one on there. 36415 is that routine venipuncture, missing, incomplete, invalid, ordering primary identifier. I've talked about that one. And also the other one with that NP not being internally associated with the billing provider, their tax ID. Next up. I mentioned to you earlier that we can view data and look at it. We can also look at trending, okay? What I wanted to do here is show you one of the examples of trending that we can look at to determine educational needs, of course, for Specialty 50 claims for that time period, that 3-month time period I mentioned earlier. I chose the claim must be submitted to the Railroad Board. During that 3-month time frame, we had 1,190 claims submitted by Specialty 50, that's nurse practitioner. The prior 3-month period, we had 814 claims submitted for the same. The difference is 376. And when I look at that trending report, remember at the click of a mouse, I can see visually a green arrow that points up, and I can see this number. There was a 46% increase in claims that were rejected for that reason from the current 3-month period to the prior 3 months. So this is a way that we can quickly look at data and determine education needs. So ask yourself again, why did Mary decide to provide education or to host a webinar on rejections and denials? Most common rejections and denials, this is the reason. I looked at the data, I looked at the top rejections, the top denials, and I looked at some of the trends that are happening to determine the educational needs. Next up, we are going to move to the next slide where I'm going to begin talking about not rejections, but denials instead. And again, this is for Specialty 50 nurse practitioner claims, just as I advertised. The number one reason why WPS denied claims during that 3-month time period, those claims submitted during that time period, was collection of fee-for-service during periods of managed care. Well, what does that mean? This is just one of those cryptic messages, I think, or what I would call cryptic. I actually went to our systems staff, our Medicare Internal Processes staff, we call it MIP, and I said, does this really mean what I think it means? And it did, because it gives me enough information to think, they're talking about fee for service and they're also talking about managed care. But what does it really mean? What this means is we denied the claim because that beneficiary has elected a managed care Medicare plan. In other words, they have Medicare Part C, not Medicare Part B. Okay, they have not chosen traditional or original Medicare. We are a MAC. We process claims for beneficiaries who elect traditional or original Medicare. We don't process claims for Medicare Part C or Medicare Advantage beneficiaries. Sometimes people call that MA. We get every single day calls in our call center, in our customer service area, where providers call in and ask us questions about a claim that was denied by Medicare, or maybe not. Maybe they just received a notice from the Part C plan. But if the beneficiary elects Part C, we can't answer any questions about their claims because you have to follow the Part C plan's rules. So you need to go to them and ask them questions. Now, CMS says that Medicare Part C plans have to offer the very same benefits as Part B traditional or original Medicare does, but they can offer more, okay? Their fees can be different than ours. So that's why we can't answer questions if your patient is a Medicare Advantage patient. You need to contact them. Take a look at the next one, the next bullet, the second bullet, and also the fourth bullet on this slide. These are most common reasons for denial. The number 2 reason why we're denying Specialty 50 claims is this is a duplicate charge. Another is the duplicate charge. It's a duplicate charge that was paid, and the remit will give you a date on claim, and it will give you an ICN, an internal control number. So these are both a form of duplicate denials. And as long as I've worked in Medicare, duplicate denials have been one of the most common reasons for denials. You can avoid a duplicate denial by stopping submission of duplicate claims. You need to do your due diligence. You need to take a look at the remit, or you need to look in the SecureNet Access portal to determine the status of a claim before you submit a new one. Okay. If you resubmit claims on a cycle basis every 30 days, stop doing that. If you hire a billing service that does that, tell them to stop doing that. It is considered an abuse, and repeated abusive actions could be considered fraud. You're trying to get payment for something you're not entitled to is the way the government looks at it. It's a duplicate denial. Try to do your best to avoid these. Do your due diligence. Look at the status of the claim. Look at the SecureNet Access portal to see what's going on with that claim. Don't just submit on a every 30-day basis or every 45 days. There's also some modifiers that would tell Medicare when you use that this is a repeat procedure by the same provider on the same day. It's not a duplicate, okay? Or this is a repeat procedure by another provider on the same day for the same patient. So look at those modifiers that you can append to a claim to tell us that it's not really and truly a duplicate charge. Otherwise, when your computer comes into the claims processing system, the computer logic is going to show same day, same patient, same provider, same CPT code, and it's going to know it as a duplicate. Okay, so do your due diligence there. The third most common reason for denial is not covered when performed, referred, or ordered by this provider. Now, keep in mind that certain services, when rendered by a nurse practitioner are not covered by Medicare versus another provider type. So pay attention to the service that you're submitting. Make certain that you can indeed perform, refer, or order the service. Okay. Treatment rendered in an inappropriate or invalid place of service. Number one, check to make certain that you're reporting that place of service correctly, or that you can render a service in that place of service. Okay. Um, Look at those employment relationships. If you're being employed by a hospital, you're not going to bill Part B separately for the services that you're rendering in that hospital. It's going to be part, excuse me, of the hospital bill. So that's place of service issue. Excuse me, just a moment. There is a CMS list of place of service. That is a resource that you can use to verify that that two-digit place of service that you're using is correct and accurately reflects where that service was actually processed. Next slide for more common denial reasons. Oh, there we go. Services are denied because the patient is in a hospice. That means that our Medicare records show that the patient has elected coverage by the home health or the hospice, home health and hospice MAC, not WPS, so we wouldn't be responsible. We're going to deny that claim. You'll need to submit it to the correct contractor. Separate payment not made for the service. Payment for some services are bundled. There is a relative value file, which is the basis of payment for all things Medicare that CMS maintains on their website. It has a status code column for each CPT code or HCPCS code that is on that relative value file. If there is a B as in boy in the status column, that means that that particular item or service is bundled. There's no way, no how you're ever going to receive separate payment for that service on any claim. Sometimes service or payment for services are bundled based on the National Correct Coding Initiative edits. So if I've included in your resources the links to the procedure to procedure NCCI edits on CMS's website. This is where two services are being billed by the same day for the same patient during the same encounter. And Medicare has edits built into the system that says the second code will bundle payment for the second code will bundle into payment for the first column code. You can look up those procedure to procedure edits or those coding combinations on the NCCI files on CMS's website to see if CMS will provide a modifier indicator that says you can add a NCCI associated modifier to the column 2 code in order to unbundle payment. Now that doesn't mean just add one. It means take a look at your documentation to see if the documentation justifies that it was a separately identifiable service that you can bill on the same day. Okay. If so, append the modifier and then Medicare can allow payment for both, as long as the other criteria for Medicare payment is met. Duplicate charge paid on claim. There's another dupe denial. Can only pay one initial visit per specialty per group. This happens fairly often for nurse practitioner claims, but effective for dates of service on or after December 1 of 2024, NPPs may provide additional information on their claim to support separate Medicare payments for evaluation and management services. This information would include specialty and the specialty that the NPP provided care for during that encounter. So there is a resource on our website. It's entitled Non-Physician Practitioners in Multi-Specialty Groups. It tells you the affected specialties, which does include nurse practitioners or specialty 50. It tells you about the rules that govern payment of E&M services. It says you can bill a new patient E&M code only once in every 3 years, as long as, or if you are within the same specialty. It requires a face-to-face service or a professional service at least once in every 3 years, or in order to bill for the new patient visit. Now, this particular resource that I talked about tells you that when the specialty for the NPP and the diagnoses are different, you can indicate the specialty under which the NPP is working on the claim, and it tells you where to put that on the claim, a paper claim or an electronic claim. You have to use the 2-digit specialty codes in the description when you're entering that information, and that will tell us that, yes, 2 NPPs saw the same patient within a 3-year period when they're working in the same group, but one was cardiology and the other was pulmonary disease. So you can add that. That's just an example, of course. So that will avoid this type of denial reason. As long as you're within separate specialties, you should be able both to bill and receive payment. So look to that non-physician practitioner in multi-specialty group education or resource on our website. The next claim must be sent to the EGHP first, and EGHP stands for Employer Group Health Plan. And this, folks, means that Medicare is secondary based on the information in our claims processing records or in the CMS master files. That means you need to send that claim first to the Employer Group Health Plan, that Medicare is secondary. We have a lot of great resources on our website, and also we have some videos, recordings of previous webinars or videos that we created specially that cover Medicare secondary payer situations. So you may want to look into that if you are experiencing denials for that reason on your claims. On the next slide, then, I am giving those common denials based on CPT codes. These CPT codes are very familiar because these are the top codes we're also rejecting, most of them, that is. 99309 is being denied because the treatment is being rendered in an inappropriate or invalid place of service, and also because that beneficiary has managed care or Part C, not Medicare Part B original, or traditional as we call it. Duplicate, 99214, and also patients, a Medicare Part C patient. The 99308, not covered when performed, referred, or ordered by this provider. Talked about that already. And treatment rendered in an inappropriate or invalid place of service. More code denials on the next slide include, next slide, please. Oh, there you go. 99213. We're denying that because of duplicate, because the patient has Part C. The G2211 is that fairly new E&M add-on code, which is inherent complexity because of continuous long-term longitudinal care. So it's an add-on code. It is a code where you always need to also add or also bill a primary service. That's why it's being denied, because it must be billed with the primary service. But it's being denied because the service isn't payable with other services rendered on the same data service. So if you don't bill the G2211 within E&M, it's going to deny. And if you also don't bill that E&M service, it's going to deny as well. So kind of really related there, those two reasons why we are denying that E&M add-on code G2211. There's, again, resources available on our website, on CMS's website, and on our YouTube channel. 99204 is an initial visit code. Only one initial visit per specialty per group. I talked about the way you can avoid this kind of denial earlier, in that we have that resource on our website that says what you need to put where if it's not or in order to show us that it is an initial visit, the first time in 3 years by that specialty, and collection for fee for service during periods of managed care. 99204. Next slide, Bailey. Here is a trending example for your specialty. This time denials. We talked about the trending for rejections earlier was the Railroad Retirement Board. But I chose to look at claim must be sent to the EGHP first. Current 3-month submissions is 6,295 claims, where we denied specialty 50 claims because the claim has to be sent to the Employer Group Health Plan. Prior 3 months was only 4,111 claims. The difference is over 2,000. It was a 53% increase in that 3-month period for this denial. Okay. In other words, what does WPS need to include in their education or continue to educate on or remind providers about? So in the advertisement, I told you that we would tell you how to fix and avoid these. So I've included um, some slides here. Much of this information is what I've already talked about when I actually presented the data to you. Modifier issue fixes, make sure that if there's a required modifier, it's there, that the modifier matches the procedure code, and the modifier is valid for dates of service. If you look at the WPS website fact sheets for modifiers. For each fact sheet, we typically include these all the time. We have a definition of the modifier, we have appropriate use of the modifier, and inappropriate use of the modifier. Sometimes we add additional information such as you can only bill this modifier with these codes, and that would be an indicator of that second bullet there, something you can check out on that fact sheet to see if there's CPT codes or HCPCS codes on the fact sheet that you can use with that particular modifier. Otherwise, your claim is going to reject because it doesn't make sense. It's illogical. Next, okay. I talked about patient eligibility. Make sure your patient name, your MBI are an exact match on the card. If the patient's Medicare card has a middle initial on it, you need to put that middle initial on your claim or you're going to risk a claim deny or rejection rather. Submit claims to the correct payer. If the patient has elected Part C, a Medicare Advantage plan, send it to them. Ask all questions about their claims to the, or, present those questions to the Medicare Advantage plan, not to WPS. Railroad Retirement Board, same thing. Send to them, ask them the questions. Provider number fixes, make certain you didn't make a keying error. Make certain that if it's required element on the claim, you're putting it there. Make sure your rendering provider is associated with that billing provider, associated with that tax ID. Ordering provider information must be entered for items or services that require an ordering provider. If there is an ordering provider, make certain you put it on the claim in the correct format, that you haven't transposed anything, so on and so forth. Next, provider number fixes we just talked about, but I've already talked to you about duplicate denials. Make certain you're not automatically resubmitting these prior to establishing status. You're billing them correctly, that you are using a modifier in those situations when a modifier can be used to tell Medicare that this is a repeat service by the same provider or by another provider. Next, here are the links for the claim form instructions that I talked about earlier. It tells you what you need to put in each and every one of the items or the boxes on the claim form. I've got the Part A and Part B information here, and I've also got EDI support requirements for electronic claims, and so on and so forth. On the next slide, the information that I am providing is how to avoid those Medicare secondary payer denials. We have a fact sheet, questionnaire, we've got those YouTube videos and so on and so forth. CMS has a web page, a lot of great resources there. Next. One more, there we go. Here are the MSP I just talked about. The next one is, next slide. Just taking a while to catch up. There is those National Correct Coding Initiative edits. I've included all of them, but the one that really popped up in your data was the second bullet there, the procedure to procedure code edits that may help with those denials of bundling where we can't make separate payment for the second service rendered on the same day as the other service. There's also the last bullet on this slide is a CMS Medicare Learning Network resource that tells you how to use these edits. I know that most of you or many of you probably have some software that does these checks for you. You don't have to manually look at them, but you really should look at them to understand them, why Medicare will not allow payment for that second service on the same day as the first. Next, more resources and tools. Talked about a lot of these already. You can use the interactive voice response system. That's that system where you can use your voice or telephone keypad 24 hours a day, 7 days a week with limited functionality outside normal business hours in order to check your claim status and details about the claim. We have instructions and an IVR operating guide available online. The next slide shows you that we also have available that SecureNet Access portal where you can check not just the status and claim details and claim actions, but you can also check eligibility for your patient. And we did see that popping up as a denial for specialty 50 claims, both beneficiary or provider eligibility issues. This too is available 24 hours a day, 7 days a week, limited functionality outside those normal business hours. And we also have that portal user manual, links on every page, the home page, and on every page to that portal user manual that includes both illustrations and step-by-step instructions on how to use this tool. We also have recordings on our YouTube channel. Next is a website resource that will help you with rejections. If you're taking a look at your remittance advice and you're seeing some reason and remark codes for a rejected claim, come out here to this resource, resource on our website. Look for those reason or remark codes and it tells you how to fix them. Fix it, resubmit it. Similarly, on the next slide, we show a website resource for denials. Sometimes that mouse wants to roll, doesn't it? Here are common claim denials. And similar to the resource for rejections, we have this one for denials on our website. And again, you can look at the reason and remark code that shows up on your remit. Come out here to this resource for denials. One nice thing about this particular resource is that we've listed those reason and remark codes by category. So we have reason and remark codes related to bundling. We have reason and remark codes related to entitlements, so on and so forth. So it just kind of helps you find your way within this resource. The next is other WPS resources. I want to point some of these out to you. Of course, we have our website. I talked about some provider enrollment issues. Make certain that you are connected to your billing clinic or your billing provider. That's a, check out provider enrollment. Pick up the phone and give customer service a call and speak to a provider enrollment specialist. Make sure that you're connected to that tax ID for that billing provider. Billing services during a hospice election. We had some denials pop up because the beneficiary was in or had elected hospice coverage. The Review Contactor Directory Interactive Map is a map of the United States, and you can click on your state to see where you send your claims. So if it's the Railroad Retirement Board contractor, where do you send that? Where do you send claims for this type of contractor versus another type of contractor? I have the Evaluation and Management Services webpage that includes links to CMS resources and all kinds of great information about the use of that inherent complexity code, that continuous long-term longitudinal care add-on code G2211. We also have some YouTube videos about the use of that code. Next slide. More WPS resources. That first bullet is that article I talked about that tells you how to avoid those new patient denials. Okay. It tells you what you need to put on your claim and where to show us that, yes, you are a physician, or excuse me, a nurse practitioner, but you're in cardiology versus the one that saw the patient 2 months ago over in another department. Live events webpage, Encore Presentations are the recordings of our live events that are available for 60 or 90 days following an event. YouTube channels there includes information about Medicare Advantage plans. I'm speeding along here because we are close to closing time here. We also have the Medicare EDI webpage. This is where you can find the link to that crosswalk. In other words, if it goes in item 19 on a paper claim form, what is it and where does it go on the electronic claim? Next slide. More CMS resources about checking eligibility. There, the second bullet is that ordering and referring file that gives you the name and national provider identifier of any provider who is eligible to order or refer services in the Medicare program. I have a link to the place of service code set if you're having place of service issues, billing in the wrong place of service or entering that wrong on your claim. There is also a link to the Clinical Laboratory Improvement Amendments webpage, that talks about that requirement that labs be certified. And CMS provides that certification number to the provider then that needs to be entered on the claim form in item 23 or the electronic equivalent. Next up. This is that interactive map that I talked about. More information about bundling. If there's a B in the status code on the relative value file, that means that service is never going to be unbundled by Medicare. Payment's always bundled. I talked to you about billing before the provider was enrolled in the guide model program. So there is a link to that Guiding an Improved Dementia Experience Model webpage. Talks about the steps you need to take. This is information you can find on CMS's website for advanced practice registered nurses, the APRN webpage. A lot of great information there, coverage and documentation, billing guidelines, and even more. And the next slide is more CMS is questions and answers. And we are at 11:01. I apologize for running long, folks. This is normally where I would open for live questions and answers. I know that I responded to some of them based on the pre-submitted questions in your registration. I've also included in my prepared speaking remarks answers to some of those questions. But if you have any questions, I'll tell you in just a little bit how you can send them. And I know that I did see a couple pop up out in the chat feature while I was speaking. I will make certain I get those answered either directly to the individual that post the question, or I will make a list of questions and answers and send all. That is if I have not already answered them during my prepared remarks. Next slide, please, Bailey. We have a survey that I would really like you to complete. Lets us know how we did today. I know we had some technical issues. Bailey was a great help. Thank you, Bailey, for helping me today. But it's so very important for you to let us know your opinion about this customer experience with WPS today, about other customer experiences. We have a lot of these surveys available. We now have them for most of the departments. So if you're asked to complete a survey, please take the time to do it. This lets CMS know how we did and what you thought about your customer experience with us. There is a survey link in the chat. Bailey did send the links out to you earlier today, given that she was going to be multitasking today and showing you my presentation, because I have no ability to advance that slide for you today or to bring that up even. So again, kudos to Bailey for helping me out. There's also going to be a redirect. When you go to close your webinar today, at the conclusion of this webinar, there's going to be a window that pops up asking you to take the survey if you've not already done so already. If you've done so, just go ahead and X out or take time to complete that survey now while everything is fresh in your mind. All right. Next slide, Bailey. This is where I thank you on behalf of Bailey and myself and our entire provider outreach and education team. There is some notes in your slide deck that tell you for a period of 7 days following this event, you can send a related question, something we talked about today, not a claim specific denial question, because I can't answer those. Those need to be answered by customer service, because we in provider outreach and education do not have access to any claim history information. But look at the emails that you'll be receiving from WebEx. You will find your continuing education unit information there, not specifically the amount of CEs, but it's going to be a certificate of achievement that tells you or that states within the body of the email that this webinar was held today for 1 hour and that you successfully completed it. That's what you need to use to turn into an accrediting body or organization in ordering to ask them in order to ask them rather for continuing education units. If you don't receive that, that means you likely called in only, that you weren't actually seeing the slide deck or the slides that Bailey was showing. In that case, you're going to get an email also from WebEx. You might get one that says, we missed you today, when in reality you really did participate, but it was by telephone. WebEx doesn't recognize that. They don't have your telephone number, so they don't know that you were actually there. If you receive that and you find that you need continuing education units, you need that certificate of achievement so you can submit it to ask an organization to give you those continuing education units, send an email to us, wps.education. Let me try this one more time. wps.gha.education@wpsic.com, and ask us to send you a certificate of achievement. Include that telephone number you called in from if you didn't actually watch the presentation today. Once again, thank you all for participating. I apologize for going over a little bit and for some of the technical issues we have today that we weren't able to control, but we made it through, and we did provide exactly the information we had promised to give you today. Thanks so much. Have a great day, everybody. You can disconnect.